Assalamualaikum doctors. In this video I'm discussing about the pleural effusion video stations. So pleural effusion video station, it is a chest. The video station come as children, that is a chest examination. They're showing like auscultation, X-ray finding also pleural effusion can be show that is effusion present, or pleural fluid aspirations. These are showing in the pleural effusion video. Okay, so DD we can keep like first of all pleural effusions, then pleural effusions, uncomplicated pneumonia, tuberculosis, COVID-19, malignancy, heart failure, pulmonary embolism, pancreatitis, part of generalized edema, example nephrotic syndrome. So these are history. Will ask OCD, what make it increase and decrease. Then first time or recurrent occur, when was the last time occur, dry or productive cough, color and amount cough, timing of cough, is it more at night, is it related to exercise, is there any shortness of breathing or cessation, if infant apnea, any musical sound, any cyanosis. Does he have any chronic illness, any other concern? Then if he FWASL, fever, weight, activity and sleep, any chest pain, breathing problems, recurrent chest infection, if chronic, ask about the previous sputum. Contact to COVID patient, travel to endemic area, contact to case of open tuberculosis, contact to COVID patient. Okay, night sweating, fatigability, weight loss, suggestive of TB. Any swelling in the body or puffy eyelids. So mainly we are targeting the DD what we keep. So in pneumonia features, cough fully, TB features we are asking, malignancy feature we are asking, and nephrotic syndrome feature we are asking, because we keep this DD. Okay. Now for pleural effusion examination, we like to do ABC, airway breathing, circulation, oxygen saturations, plot the child on the center and assess the vital signs, clubbing, cyanosis, BCG scar, erythema nodosum, and chest and cardiac examination, abdominal examination for ascites. Investigation for pleural effusion is that full blood count, clotting skin, urean electrode, LDH, protein, albumin, glucose, CRP. So septic work we are doing, blood culture, sputum culture if possible we are doing. If recurrent infection, they investigate for the immunodeficiency. First line full blood count, immunoglobulin GAM, functional antibodies and HIV antibody. If risk for coagulopathy and thrombocytopenia, check and correct drain insertions, pleural fluid analysis, radiology, ultrasound scan of the chest, chest X-ray. Okay, so suspect indication of CT of the chest we do, suspected malignancy, suspected tuberculosis, not improved after 3 days and complicated by cavitation or fistula. Management of pleural effusion is that multidisciplinary team I will involve pulmonologist, anesthesia, cardiothoracic, interventional, radiologist. Then ABC, analgesic, oxygen, IV fluid if needed. Antibiotics we are given for community acquired IV amoxicillin plus clindamycin. Okay. Hospital acquired we are giving tazocin, aspiration, tazocin. Tuberculosis team we involve and emphysema, IV ceftriaxone and clindamycin. Indication for referral to pulmonologist is that enlarging or compromising respiratory functions and underlying cavitating disease, bronchopleural fistula. Then chest drain insertion, we can do the chest drain insertion. We can respiratory pediatrician, we discuss about that, and then we are doing that. The team multidisciplinary team radiologist they do this. Surgery needed when discuss with the pediatric thoracic surgeon if there is effusion not resolved and child is still septic. Follow up after 6 weeks with the respiratory pediatrician, X-ray to be done on arrival. So pleural effusion we understand the child can be respiratory symptoms like shortness of breath, respiratory distress on oxygen can be present. The child they can show that chest examination, inspection, palpation, percussion, auscultation of the chest. Then also we see that reduce the breath sound one side, stony dull finding. Also we can find that is someone is drainage, pleural fluid. X-ray also they can show. So this is pleural effusion. DD we are uncomplicated pneumonia, pleural effusions, emphysema, pneumothorax. We can keep foreign body, heart failure, malignancy, tuberculosis, COVID-19, even nephrotic syndrome. History we ask onset, course and duration, make it better and make it worse. Okay, the cough description like dry or productive cough, chesty cough, sputum production or not, what is the color of the sputum, content of the cough. Then about any blood in the cough, it is nighttime, daytime, nighttime is much more or not. What about his fever, weight, activity, sleep affected or not. For malignancy we are searching, nighttime very important, BCG mark, child is vaccinated or not, family history of similar conditions. We keep nephrotic syndrome, so any other body part swelling or not. These are any chest pain, breathing problem, shortness of breathing, recurrent chest infections, any chronic illness, because TB we are keeping exercise intolerance, cessation of breathing, apnea, any musical sound. These are we are asking. Examination we do airway, breathing, circulation, dehydration status, vitals, heart rate, respiratory, blood pressures, oxygen saturation, very important here, capillary refill time. Chest examination, cardiac examination, abdominal examination. Also, we check that we are checking clubbing, cyanosis, BCG scar, erythema nodosum. Investigation full blood count, ESR, CRP, septic work we do. After that, we are doing the blood culture, sputum culture. We are doing chest X-ray, AP view or PA view. Ultrasound of the chest we can do. CT, MRI, some indication like suspected TB or malignancy, or it is not resolving this issue. Then we can do urea electrolyte, LDH, lots of disease, other infections we can search. If we think TB, so Mantex test. So pleural effusion treatment, what we give? Uncomplicated pleural effusion, we give IV amoxicillin. First of all, multidisciplinary team will involve pulmonologist, anesthetist, cardiothoracic, interventional radiologist. ABC, analgesic, oxygen, IV fluid if needed. Then antibiotic community acquired, we are giving IV amoxicillin plus clindamycin. Okay, IV amoxicillin plus clindamycin. Hospital acquired, we are giving tazocin. And tuberculosis, if then tuberculosis team will involve emphysema, IV ceftriaxone plus clindamycin. Then we are chest drain insertions. If needed, pulmonology to be referred. If there is enlarged and compromising respiratory functions, underlying cavitating disease, bronchopleural fistula. So chest drain insertion we give. Chest drain insertion discuss with the respiratory pediatrician, consultant pediatrician, pediatric anesthetist team, usually general anesthesia used, and PICU, cardiothoracic team, and interventional radiologist. Then we are pediatric, even last pediatric thoracic surgeon. Surgery also if the issue is not resolving, effusion not resolving, child is septic, and after 6 weeks respiratory pediatrician X-ray to be done on arrival. Okay, after 6 weeks we will be follow-up. This is all about pleural effusions video station where we give the antibiotic IV amoxicillin plus clindamycin. Hospital record we are giving tazocin, and if it is emphysema we give ceftriaxone, clindamycin. Then we are chest drain insertion we do. Thank you.